I'm Nancy Myers. I work at the American Hospital Association, and I'm joined today by three great panelists. Julie Orban, who is the project manager of mental health matters at Columbus Regional Health, is joining us today. Derek Van Brunt, who's a clinical professor at UC Berkeley in their School of Public Health, and also the CEO and founder of Credible Mind, and Debbie Zerner, who is the Director of Community Engagement for Owensboro Health. Thank you all for joining us today. Last time when we had a conversation, we focused on the why and the what of population behavioral health. And today, we're going to get more into the how of it works in terms of what does it look like, how it scales, and most importantly, I think, the use of digital and AI technology to support individuals and communities, which is something that I hear more and more from leaders across the country that they're interested in exploring. This is meant to be a structured but informal dialogue. So please, throughout the conversation today, go ahead and use the Q&A function to insert your questions into the chat, or even your own thoughts or experiences as we go along, and we'll make sure to work them in. And we will have a little bit of time dedicated at the end for any leftover questions that we have not been able to address. Derek, I think that I'd like to turn it over to you to start us off and maybe give us a little bit of recap on the topic of population behavioral health, and then set up our conversation for today.
Well, Nancy, thank you, and hi, everyone. Good to be with many of you again. So as Nancy mentioned, this is part 2 of a 3-part series, and I'm going to take just 2 or 3 slides, and for those that didn't make part 1, try and catch you up a little bit. So our topic is population behavioral health, and really all we mean by that is adding prevention and early intervention to augment and to work in parallel with clinical care, and create navigation so people can find the right level of care. So those are basically what we're going to talk about. Next slide. So why does this topic matter? What's important here? And I'll call out just 2 or 3 things. First, we still have elevated rates of a variety of mental health conditions in this country, such as depression, anxiety, etc. And we still have an average of 8 to 10 years from the onset of symptoms around something, a mood disorder like anxiety and depression, to when people engage with clinical care. That's a long time for people's trajectory to result in maybe a condition getting worse. We're sort of failing to intervene earlier. And early intervention works. About 1/3 of our country lives in the equivalent of a food desert, except it's a mental health, a professional health desert, where there's an insufficient number of professionals to serve people. And the costs related to all of this, when there's a comorbidity of a mental health issue and a physical health issue, are anywhere from 3 to 7 times larger, which, if you have like value-based contracts, is a very big deal. Meanwhile, there's a tremendous opportunity, which is, of people with mental distress, about 3 out of 4 just want to know what they can do to feel better, maybe for themselves, maybe for a loved one. So the opportunity is to help the 3 out of 4 help themselves and sort of clean up the system so that it's not we're not trying to serve all people with professional services. Next slide. So what is this population behavioral health model? And there's an article that was written, and if you just ask, we happily can send you the copy. It's more of an academic paper explaining the opportunities and the science behind the efficacy of early intervention and prevention for behavioral health. But basically, this is the bottom line. We're talking about having a digital front door. It could be for your community, for patients, for workforce wellness. And it's a place where people can find everything. They can find evidence-based self-care to help the 3 out of 4. They can take assessments so they can find out what their risk levels are. And they can be connected to the right level of care that might be peer-to-peer support, or coaching, or therapy, or medication management, as we think about the stepped levels of care. Next slide. So let's just take a quick look at what are some of the technologies that underlie this sort of digital approach to scaling population behavioral health. And let's look at a few just screenshots to familiarize ourselves. Next slide. So this is a list of just technologies and capabilities that are made available when you start using technology. Here's what the color coding means. The brown are what I'll call traditional technologies, and the sort of aqua are AI based. So I'm going to talk about each briefly. So when you have a digital front door, you can lower access and barriers to access. Imagine rural communities where people have long drives to get to professional services, but they can just sit there on their phone and in many cases get a lot of help instantaneously. You can identify risk very early when people take risk assessments, both for themselves as well as looking at the aggregated data. You can identify risks in people and populations. Technology can help personalize self-care and navigation. The system can sort of see what people do, not that they know who they are, it's all de-identified data, but if someone is continually clicking on certain topics, then you can start personalizing their experience so it's more valuable. And finally, all of this is capturing real world data, and I'm using that term real world in the current sense, which is not academic, a randomized controlled trial, which doesn't necessarily play out in a population. These are real people at home, at work, and we're seeing what they're suffering from and what's helping. So those are some of the uses of traditional technologies. Now, we can also use AI in responsible ways. And I know there's a lot of sensitivity around AI these days. So when I think of using artificial intelligence, and there are a variety of different tools, I break them into two categories. One is what I'll call under the hood. You don't really see it working, but it does a lot of wonderful things. A lot of efficiency is created. And then there's the more conversational interface that we all read about, like with ChatGPT. So under the hood, AI can help with guided intervention pathways, which means it can suggest resources to an individual based on looking at multiple data sets and putting that together in a way that no individual ever could. It can identify risk and insights across data and populations because of just the sheer volume and real-time nature of what it looks at. And then finally, it can actually support clinicians with everything from augmenting the diagnostic process with different screenings to making available tools between therapy sessions. So all of these are capabilities that AI can provide without ever running into what we call the phantom problems of AI making things up. Next slide. I'm just going to share a couple of slides of what does this stuff look like. We're going to hear from in a moment from Owensboro Health and Columbus Regional, but this is Intermountain Health, very innovative health system in the Mountain States. And they use this population behavioral health platform for 3 different populations. The communities, the people in the communities they serve, so community health, for their own workforce wellness, and to help with member/patient care. So you can use it in all 3 mechanisms, what we like to call inside and outside the walls of the hospital. So what can you do here? You can look up topics, any topic related to mental health, like depression or anxiety, see what science says you can do to feel better, and connect you to resources that have been vetted. You can also find resources in the community, like through 211 and United Way and other groups that meet. Next slide. There are immediate practices where you can just say, I'm really stressed and I'd like some help doing a breathing exercise to calm down right now. And there are assessments where you can find out across 20 different topics what your risk level is. And these are very popular, and people often take them on behalf of someone else, a sibling, a child, a parent, someone they're worried about, and maybe they even have a language barrier. They ask a few questions, and they can find out how serious is this and what are appropriate next steps. All of that is being supported today by Intermountain and many other health systems around the country. And then finally on the right, you see a bunch of personalized filters. These run passively in the background. We can see things. Again, we don't see any individuals, but we can see whether people always click on they like videos or podcasts, or they're always looking for apps. This is a person who learns by hearing people's stories, or someone else just wants the facts. Someone else always looks at topics through the lens of a parent, not for themselves. These are the kinds of things we can pick up that then personalize the journey going forward. Next slide. And I actually talked to all of this. Next slide. So let me just wrap up here. The idea is to give you a quick introduction of this, AHA Credible Mind Partnership Platform, the behavioral health platform, which is now in use all around the country. So over 200 communities, all the green colored states, have at least one, in many cases, half a dozen, implementations of this system, and it is working at scale. Today, over 50 million people have access to this platform. Next slide. And it's working great. I'm going to give you two examples of outcomes. One that's more organizationally relevant for the hospital, and one that's more personally relevant for the users. For the hospital, what you can look at, and your partners, your community partners, is that one, what people are doing on the site is what we call meaningful use. They're not just looking at a front page and bouncing around. They're taking assessments, watching videos, finding a local resource. That's a very high percentage. Of those that take assessments, if they have low risk, they're 81% more likely to go into self-care. Now just pause and think about that for a minute. We don't have enough behavioral health professionals in this country. 81% more likely when someone's lower risk, they go right into self-care. It never hits the system, and they get immediate support. And for those that score higher risk in assessments, they're 33% more to go find clinical resources. So that's a naturally self-selecting triage mechanism to help people find the right level of care. And again, with tremendous return on investment associated with that. Next slide. And then from the user perspective, over 90% say it's helpful, they like it, they refer it to a friend, but I'll just share what I think is the most important stat over on the right. Over 50%, whenever we ask through these surveys, are reporting that they're making positive behavior change. They're sleeping better, they're less angry, they feel they're a better parent. And that's what really just gives us a smile every morning when we wake up, as we start giving this to people at scale in our communities. Next slide. So to recap, this is technology-enabled population behavioral health. It integrates everything that you're doing, all your clinicians, networks, programs, resources, anything that you're doing. This is just meant to be an organized entry point that adds self-care and assessments and triage, but integrates everything that you're already doing so that it all works as one system. And you can do this for the community. You can do this to help our workforce because we're suffering here in our healthcare delivery workforce. And you can use this inside the walls with patient care or member care. So let's turn it over to why most of you are here, which is perspectives from the field.
Yeah, thanks so much, Derek, for laying that groundwork, and wanted to turn to our two health system experts to hear a little bit more about how this concept of population behavioral health and these tools that you've described or started to describe are working in their communities. So, Julie, if I may start with you, tell us a bit about your organization and your community and how you've approached community mental health.
Thank you, Nancy. Columbus Regional Health is located in Columbus, Indiana. For those of you that are not familiar, we're about 40 minutes southeast of Indianapolis, Indiana, home of the Indy 500. Our health system has more than 2,400 employees, 225 physicians on staff, and well over 250 volunteers. And it serves as our anchor facility for our 225 bed. We are a not-for-profit hospital providing emergency and surgical services. We also are very proud of that we have a Nexus Park system, which is a primary and specialty care facility, which connects care coordinated services and opened early in 2024. And this is part of an also community-wide recreation and wellness campus in partnership with our city of Columbus. And we're also proud to say that we're a Cleveland Clinic connected partner. One of the things that Columbus Regional Health does every 3 years is we do a community health needs assessment. And a result of the last assessment that we did, mental health, as I'm sure in a lot of other communities, rose to the top as far as a need that had been addressed. And the health system always tends to lead that and then has the key community partners involved. So our city, our county, our schools, and as well as our United Way community. And as we started to walk through this process of engaging community members as well as our key stakeholders, we started asking the questions of what is the gaps and barriers and how can we improve those. And one of the things, and Derek's spoke to that so very well, was the access issue. There's others issues, but it became very clear to us that what we needed to do was address that. And one of those ways that we immediately stepped up with assistance from our community partners was to implement Credible Mind well over about 1.5 years ago. So one of the other things that we have done, and as we rolled that implementation out, is that we knew that part of the issue of individuals wanting to receive help deals with stigma. It's not something, I laugh, and I've even used a personal story. I would probably go in and talk to my team and say, hey, I'm going to be late because I'm going to do my annual mammogram, and everyone claps their hands and says, Julie's doing a great job. She's taking care of herself. Would I feel as comfortable saying I'm going to be late because I'm going to talk to my therapist? So one of the things that we worked very hard about is to integrate the rollout of Credible Mind and also trying to eradicate stigma within our community is we did a parallel approach. We developed what we called our Standing Up Stigma campaign, and we also developed what we called an ambassador network. So all of these individuals that you see on the slides there are individuals that live, work, and play within our community that were willing to stand up and share their journey with us in regards to mental health. The other beauty to it, if you notice, there are QR codes on these flyers that take the individuals from that information of their journey to content that is available within Credible Mind. So like the first one, when it talked about suicide, depression, it goes to the content on Credible Mind. The other thing that we have done very well, and creative ideas have come from our community, was how do we reach people where they are and get them to feel comfortable about utilizing the content. I know it's hard to see, but the content in the center, we have a doula program at the hospital, and the doulas came to us and said, mothers can have postpartum depression. Can you develop a card for that? So that is the one on the right. Our health department came to us and said, we distribute the death certificates within the community. Can you develop a card about grief? People are uncomfortable talking about grief in its regards to mental health. So we did that. And then we just have a generic one in the middle. And then, as you can see, we've done coasters, we've done the typical water bottles, and we've also done coffee sleeves just to help individuals feel comfortable that the information is there, but yet it's subtle and they can easily access it.
So a question in the chat, Julie, is around the use of peers or community health workers as part of this programming and this continuum. And it sounds to me that your ambassador program is similar to, or maybe an extension of the idea of a peer support program. Can you maybe talk a little bit more about, how people access that peer information and how it's been helpful, especially around destigmatizing support?
Sure, great question. Thank you. What we did is we worked on this program and or the initiative and rolled it out. Is we literally went out in the community and networked, because one of the things we knew is that we had to go to people to make sure their voices were heard. So we have individuals, low income, LGBTQ, biracial, all kinds of different entities in the micro community that are at the table helping us as we develop these materials. Those individuals also then will be an extension of us to go out at community events. We have a very small team. Currently, 2 people retired, so it's 3 of us that are left. So we can't support all the community events that we want to go to. So these ambassadors, they're volunteers. They have their primary job. They do this for us because they're passionate about mental health, improving others' mental health. And so they have volunteered to do amazing things. They've mentored senior projects. They've had health fairs. So we can get this information in front of people and in easy access, and to meet people where they are so they'll feel comfortable. And the key to these ambassadors that we have found is they're trusted. So if they see something that comes from an ambassador, or it has the Mental Health Matters logo on it, we have heard from people to say, we trust that content. We know it's valid. So between Mental Health Matters and Credible Mind, it opens doors for us because of our ambassadors. This is the first time we've ever done this with an initiative, and we believe it's been a resounding success, and highly recommend anyone trying it, and we'd be willing to talk to people if they'd like to hear more about it.
And just one last clarification point before we get to Debbie. So the ambassadors, you said that they're volunteering to be spokespersons for this programming and to support the community. Are they coming from, do they work for the health system? Do they work for community organizations? What is their day job?
We have a variety. We have some that work for IU Health. We have some, they're teachers, they're librarians, all walks of life. And one thing I failed to mention, but we also spent a great deal of time training them before we launched them out into the community, if we will. They went through mental health first aid. We took them on tours to resources within the community and everything. So we prepared them. They've seen Credible Mind. They use Credible Mind. So we spent a great deal of time preparing them as before they went out into the community.
Great, thank you.
You're welcome.
So Debbie, let's turn to you to get a little bit of background. I know that you've been working with community partners at Owensboro Health for a few years now to focus on improving mental health in your community. Tell us about your approach.
Okay, let me first tell you a little bit about Owensboro. If you're not familiar with Owensboro, Kentucky, and I know we have quite an audience today. So Owensboro Health is nestled on the Ohio River, about an hour and a half, 2 hours west of Louisville, Kentucky. You plug the Indy 500, so I'll plug the Kentucky Derby. So we are about 2 hours west of Louisville, and our community itself, both the county and the city, is about 103,000, and that's combined, but we serve an 18 county region here in Western Kentucky, and most of those communities are rural. We do have 2 additional hospitals sitting in 2 rural individual communities, and so we have many challenges. In my role as Director of Community Engagement at Owensboro Health, a little different than what you might think of community engagement, but we are responsible for conducting, as we were describing previously, about community health needs assessments for nonprofit hospitals, and I think Derek mentioned that as well. We do have to conduct a community health needs assessment every 3 years and draft an implementation strategy. And we do so and time after 2012, when that came through the Affordable Care Act, that it was mandated for all nonprofit hospitals to do this work. We have seen mental health rise every single time that we have done these assessments. And I'll tell you, from a community standpoint, everybody says we need more providers. We need more providers. Now think about what Derek said. This is 2012, 13, 14, 15. And when they were creating and launching Credible Mind, and for the purposes he's described, it is because we cannot hire ourselves out. We cannot hire out of this issue of lack of providers. And so when Derek approached us in 2019, it was right before COVID. And then, of course, during COVID, we got really intentional with our decision. So we were utilizing a digital platform. And this is, again, within COVID. We launched that and immediately saw that people were using the platform. We then began to go down the road of seeing what more we can do strategically. We know we've got a good intervention, and we know we're reaching people by the numbers of the who is using this platform, who is assessing, who is taking the assessments, et cetera. But we needed more information and structure. So that's when we participated in the AHA Hospital Learning Collaborative. So we did so. And from that, the hospital decided to establish a mental health collaborative in the community, whereby we brought in our community mental health center, which was River Valley Behavioral Health, and you can see that on this slide, and our Green River District Health Department. This collaborative is really, we've charged ourselves with looking at the issues from policy to advocacy to integration of services to reduction of stigma, et cetera. But the one thing we started with and knew we had to get into the hands of more people was Credible Mind. Credible Mind is hence its name, a credible resource. But if you do not have that one-on-one conversation, understanding with various groups in your community, you really lose the ability to show them what it is and how it's used. That takes time and it takes intention, and that is what we've done. We know that last year we surpassed over 10,000 assessments that have been taken. We're looking very closely at what ages are the individuals who are using this, and it's really crazy because our teens and our 18 to 24-year-olds are using this in really high numbers and consistently so. So we know we've got to get it into the hands of everyone. It's not that others aren't using this. They are, but how do we get it to them? How do we take it to them? So when we formed this collaborative, we too created this awareness campaign of this resource. And in doing so, as we were discussing in terms of stigma, we've got to reduce the stigma. We've got to be able to normalize it's okay not to be okay. And that was what you saw on our landing page. So these three entities got together and created a campaign, if you will, but all of us, we put in funding and time and resource and expertise to this. And here was our four main messages: is that your mental health matters just like anything else. Just like getting your mammogram, just like having your A1C tested. I mean, your mental health matters. We really have targeted that seeking help is a sign of strength and not weakness. It's okay not to be okay, and that's where we started. And mental health is health. And we have a number of tools that we use, everything from yard signs to stickers and so on and so forth. But what has been so valuable is the individual reach out to, let's say, school systems, where one of our school systems in our one of our rural communities has placed now every student receives a laptop. And in middle and high school, there is a sticker that went on them as they were issued with a QR code to reach Credible Mind. We've got to get it in their hands. Another one, it put it on the back of the bathroom stalls for them. Yet another one of our engagement coordinators in a rural community met with their Better Breathers Club with COPD, and she utilized one of the breathing exercises that you can access on Credible Mind, and she used it with a number of individuals who have COPD. I could list these kind of examples over and over again. I was just at a seminar where they were talking about community college students and how many of them, and it was well over 50%, admittedly say they deal with anxiety on a daily basis. We got to get it in their hands. We know the information is good. We know it's credible, but I can't just tell you about it. I have to show you. I have to guide you. And so I love the ambassador program. I think that's a great idea. We're doing those handoffs to be able to educate them on what it is, and then let's see and hear from our community where it is they think it would be best to put this information. So that's kind of how we're using it. We're using it internally at Owensboro Health. And I will tell you, from 2010 to 2012, all the way up to so before those health needs assessments, we've had some real horrific weather related events here in Kentucky. Back in 2021 and then 2022, we started with tornadoes on the west side, flooding on the east side. We've had horrific hailstorms. When I say 30,000 roofs in one community, that's what we've dealt with. There's a lot going on in this world, and you add that weather component to it, and losing your home and schools being closed and those types of things. We reached out to Derek's team and said, okay, we've got an issue here. We need to put front and center. What do we do in times of weather related trauma? What do we do in terms of what can we put on that site front and center that says it's okay not to be okay, and here are resources available to you? Got some great stories I'd love to share. I could spend the afternoon sharing those stories with you all, but it's really taking it into the community and guiding the community as to what it is. We have a lot of noise right now. We don't know what to believe, what's real, what's not real, what's true, what's not true. The number one key to working with our community health mental health center was that they understood that the information on Credible Mind is evaluated, it is vetted by teams of experts. And when they went in to look at the various populations that they serve, and they are predominantly the provider of mental health services in our community, they knew and they trusted it. And because they do trust us and your health department and the community mental health center, that has just added to that ability to have a communication about this is something you can use and it is valuable. We also, I didn't say, and we didn't spend a lot of time on that face page, but we have put in all of the 18 counties that we serve their local resource information. And that's very valuable because when we're serving 18 counties, and some of those, again, being rural, they are looking at that site, and then they can launch from the Credible Mind site to a local resource. And of course, 988 is front and center, and it will be always. But those are the resources that you can add, and we have done so. And in the back end of that, we've been able to track how many individuals have landed on our platform and then reached out for, it could be a support group, it could be the crisis line, it could be a higher level of intervention because they have taken those assessments. And I will tell you, lesson learned. I did not know if people would take assessments or not. And when we hit over 10,000 assessments taken, we were shocked. These aren't, 2-question assessments. These are assessments that you've got to sit down with, and they vary in length, but people are taking the time to explore and to take care of themselves. So it's been, we've got a long way to go in terms of who we need to reach to be able to get to our senior population. When we look at our suicide data, and unfortunately, I think at your last session, I think it was Dr. Adler who had said that nationally it looked like the suicide rate has decreased a little bit. Not here in Owensboro, Davis County. It has. We're tracking to exceed last year. Those are all ages. And that is another blatant reminder to us that we have to get this resource in the hands of all ages as well. Because, we've got things such as the River Valley Behavioral Health is teaching mental health first aid. They're teaching both the adult version, the adolescent version. We're trying to complement. This is a complement to all things that they are trying to do. Because I guess I'll end where I started, and that is we cannot hire enough professionals, and nor do we need them in every turn. We need a platform such as this to be able to seek that self-care and then seek additional intervention if we need to. So it is a complement to all things that a community is doing to address mental health.
Thanks so much, Debbie. So much to dive into here. And so as we move into taking some slides away and just getting into discussion, I did see that there was a clarifying question for you, Julie, in the Q&A section of the site about the ambassadors. So I just want to touch on that real quickly first. So they're volunteers. They come from all walks of life. Do you reach out to them? How do you make the connection with them? How does that happen?
We have my co-partner in crime, Vachel Hudson, serves as our ambassador project manager. So essentially, we just started networking with individuals in the communities and had what you could say kind of a call out. And then we would sit down with individuals and interview them and talk to them about why do you feel like you would be a fit, and ask them if they would be willing to make this commitment. I mean, it was in the beginning a very significant time commitment on their part of, several evenings, at least 2 to 3 a month, where we would spend 2 or 3 hours again, making sure they were touring resources, attending training, mental health first aid, and everything. I think I might have heard you say about compensation. We talked to them about that. We haven't compensated them. Typically, we feed them at trainings. They like swag, so they have shirts that say have our logo on them and have ambassador on the back. And we bought them some beanies for winter events when they're outside, and they thought that was wonderful. So it's strictly all volunteer networking. And things of that nature. One thing, I want to digress a little bit. I wanted to play off something that Debbie said about our youth and what we're seeing. Our age group is girls 13 to 17 since the beginning has been our predominant users. But we are seeing a significant uptick in our mature, I like to say, since I fall in that category, in our mature clientele that are coming to Credible Mind and looking at the content, looking at aging, longevity, how do I flourish, things of that. And, Debbie was so eloquent about what she said. We too have a suicide overdose fatality review team, and we look at that. And unfortunately, we've had some very high numbers. Ours have been males. So there's a focus there. And how do we get that stigma about I always have to be the strong one and things of that nature, and get specialized content to them? So thank you for letting me digress.
No, I'm actually glad you brought that up, because one of the things I had written down to ask all of you about, so maybe I'll turn this question to Derek since you haven't commented on this yet, is to talk about for the platform and for this type of resource overall. It seems intuitive to me, as one of those people in the mature population, that folks that are younger than me would find this very natural to use and as a way to get to resources that are best tailored to their needs. But what are you seeing nationally in terms of the spread of people using the platform? Is it pretty equal across all age groups? Are there clusters?
There are clusters. The first thing is it's mostly women that use the system. About 70 to 80% of utilization are women. It's about 50-50 coming in on mobile devices and their desktops. And in terms of age groups, there is definitely the highest is the youth, and then it's fairly equally distributed as you get older.
And then let's talk about the system. So I want to stay with you, Derek, because there have been some questions in the chat. So people come, to this resource as a front door and can take an assessment or not, and begin to explore resources that the more they interact with the system, the more tailored both the resources and I love that the delivery methods, how they receive information becomes tailored to them. Can you start by talking a little bit more in response to an audience question about the resources themselves that are vetted and part of this platform? What is that vetting process? How do you identify resources to include, and how often are you checking them again?
A very important question. There are many different components when we talk about content. So there's original content that our clinical team writes, and that is all, peer-reviewed internally and cited. So there's that content. There's what are evidence-based approaches. If you have anxiety, you quickly learn there are 16 different things you can do that help reduce anxiety, symptoms of anxiety, like sleeping better and exercising more. So you learn things like that. That's from our clinical team doing consistent research on the literature. And then there's pointing people to resources. It's sort of the last step. And these are apps, videos, podcasts, articles, etc. And again, that goes through our content team. And they have a peer process, and there's a rating scale, and we can share that information with people. So everything has been looked at both in a quasi-automated way. So for example, somebody writes a book, we're looking at Goodreads and how other people rate that book, but we're also looking at how other professionals rate that book, like out of Harvard Divinity School. What did they think of that book? And so we take all of that information and automatically roll it up. Then our human team looks at that and says, yes, that makes sense. These people love it. These people love it. I've looked at it. It's good quality. Check, go. So it's it's not a complicated process, but it's a fairly elaborate process, and it's continually updated.
And then, I'm really fascinated, and you talked at the start of your remarks about how the emerging world of AI is coming into play. You just talked about how it helps you with vetting resources, but I'm interested in what the role has been in terms of helping people, and how you, as the CEO of the organization and your clinical team, kind of balance how to use AI with concerns around person level, safety and satisfaction and privacy.
So we use AI today in a variety of ways. I'll give you one or two examples. And we also don't use it in certain ways today. So let's sort of get to the bottom line, which is the bad rap around AI. There are many concerns, but one of them is it's well documented that AI conversational interfaces, like a ChatGPT, when you ask ChatGPT, I'm contemplating suicide, and then occasionally these things come back and say that's not necessarily a bad idea, that's a problem. So there are a variety of concerns that people have around that. So I'm going to come back to the conversational interface, but that's what's getting the attention. But the efficiency tools of AI, for AI to look at an impossible amount of data and come back with insights that probably no human would find unless they spent a year with the data. And I wouldn't call them, they're not conclusions. I mean, I'm an epidemiologist by training. What it does is it creates wonderful hypotheses. Why is it that in your community you have a disproportionate number of youth that are scoring very high risk for substance misuse? Why is that? And maybe where is that? So that's the kind of insight. Or
look across 1,000 resources and pull summaries of them so that someone isn't sitting there handwriting a summary for everything. They can just review the summary. So these are efficiency tools, and just be blunt, they're a no-brainer. There is no risk. It's an efficiency tool. But now let's go back to the conversational interface, and I'll sort of, just drop the thunder. We've already got it. Nobody on this webinar is using it with us because we haven't launched it, but it's already built. We've got the AI conversational interface for end users to use our system today. Imagine how nice that would be. I use it, and I use it for myself because I can be careful, and I ask it questions, and it can immediately lead me to vetted resources. It doesn't lead me to something out there on the web that isn't vetted. So we've got it contained with guardrails so that you get the benefit of the conversational interface, but it can only point to the resources of the sponsoring organization, their clinical teams, partners, etc., or the content that we provide that's validated. So we're very excited about this. We could launch it very soon. To be blunt, I don't think our clients are ready. And so we're going to be talking to some of our, closer partners to say, do you want to do this? How should we try this? We'll be rolling it out early next year, but that's where the sensitivity is. And that's where we draw that line, Nancy.
Right. And one other clarifying question for you that's in the chat is how much of the content on or in the system is coming from Credible Mind, either your own writings or your what you find in searches versus what percentage comes from any given sponsoring organization?
Oh, the vast majority comes from Credible Mind. I mean, we have summaries for every mental health and well-being topic, evidence-based approaches, and over 15,000 resources that have all been vetted and growing. So all of that's us, plus newsletters, insights, immediate practices. I could just list. All of that we do, and it just works, including if someone scores at high risk on a depression assessment, immediate 988 and crisis lines and things like that. So it runs autopilot with nothing from the sponsoring organization. That said, for the bridge players in the group, our partner has the trump card. They can put anything they want in it, and there are tools to do that very simply. So you put on your branding. You can list your clinical teams. You can, if you have a license to the Calm meditation app, it can pop up first thing on appropriate related topics. So anything that your organization and your partners have can easily be integrated in so that it's seamless to the user experience. They can see all the stuff we do and all the things you do on a page nicely together.
So
Nancy,
go ahead.
I'm sorry. I just wanted to interject at that point too. And Derek's exactly right. While we hold the trump card, we want people to experience what Credible Mind is and what it has to offer. And so we do put those resource tabs for each of the counties within our service area. And that is crisis intervention. That is your local crisis numbers. That is your 988. We know that 211 with United Way, and there's a multitude of other resource directories and platforms that you can access. We really focus on the content of Credible Mind here. And so with Owensboro Health, it's very clear if you do go to healthymind.crediblemond.com, and you will see that's very clear that first and foremost, you will see the branding and you will see the resources, but you land where you need to be for Credible Mind.
So Debbie, I want to stay with you. Both you and Julie talked about, as part of your approach to community behavioral health, is the importance of collaboration with other organizations, with individual ambassadors. So, and you mentioned, Debbie, specifically talking about, and you just brought it back up again, about using this platform as a way to highlight resources from your community collaborators.
Mm-hmm.
How has this tech platform and this type of approach supported collaboration? So has it brought you to a different level in working with your community partners?
It has, and this work cannot nor should it be done solely by a hospital or a health system. It can't be done. Too many players within your community, entities, for-profit, nonprofit, all are providing services in this space to really focus in on mental health and well-being. And I say that a lot, and I think that's critically important. They have resources that we do not have. They have expertise that we do not have, but they do. They reach various, some reach specifically the older adult population. We have to be able to work with community partners across the board. The collaborative helped with that. The Learning Collaborative helped us really name who those partners would be. And we have started small when we developed this mental health collaborative, because we really have to think, one, who is leading this, right? Who is leading this? And then what are the strategies and what are the needs for and from your community partners? Because they have needs too. But also they come with a tremendous number of resources. So the collaborative itself has strengthened in its intentionality and its strategy versus let's getting together to talk about how mental health is an issue for all of us. And then we talk about the various sectors and you talk about what you don't have. This has put us into action mode.
Thanks. And, Julie, I was struck during your conversation earlier about how you've had partners come to you, the doula program, the coroner's office, asking you to help them by developing kind of customized advertisements or marketing about the availability of resources like these. Have there been other ways that the tool itself has really helped you to collaborate differently and more responsibly within your community?
I would say absolutely. And I would say ditto, amen to everything that Debbie said as well from a collaborative standpoint. I think it has enabled us to sit down and have, like Debbie said, instead of just mainly focusing on this is an issue, this is a challenge, how can we work together instead of being in our silos, but being on the same page, if you will, to say, okay, if I'm coming to Credible Mind because I have anxiety and depression as a result of domestic abuse. So we work with our domestic abuse partners about what's the content, how can we drive them to you, how can we put a link from their site to our site and promotional materials that we can work with them. But yes, I mean, it's all about sitting down and saying, okay, additionally, where's our gaps? Where's our barriers? What are we missing? How can we continue, as Debbie said, get it out there, get it out there, get it out there. I mean, one of the things that we heard loud and clear before we implemented it was, and as Debbie said it very eloquently, we cannot provide ourselves out of this. We just don't have enough. We're never going to get to that level. And even our providers told us when we finally get to someone, we see a lot. If it's anxiety, it's depression, it's things of that. If they had this tool, they wouldn't even have to be in that pipeline. So if we can remove some of that, then we can care for the people that really need that one-on-one therapy. And we have seen that help with our providers, that our wait lists have come down.
Yeah, Julie, we're seeing that too as people become familiar and maybe they haven't navigated it to its fullest extent yet. And so they'll come to us and say, okay, on our back to school night, we'd like to be able to give information specific on vaping or specific on anxiety or peer relationships or bullying and those kinds of things. And so we've worked with the Credible Mind team to develop those. And I see you have cards. I love them. We've had flyers that we have made, like smaller flyers for parents to take with them. We had some representatives from our entities that serve intellectually challenged individuals, and their mental health needs are critical. There's not a lot of providers who are specialize in this area, but they are able to go to the site and get information that leads them to ask more appropriate questions and get the help they need. So it's been interesting to see people navigate it and then develop more questions about what about. And when we don't have the answer, we will go to our representative and Derek and others and say, okay, we've got an entity or an organization looking for this. What do you have? I even challenged a student one year, and I said, I want you to just spend time navigating this platform and come back to me and tell me what you think. And she did, and I sent that to Derek, and what she was looking for was found, but it took a few more clicks to find it. And so Derek and his team wanted to assure her that they would be addressing that and providing instruction to the teens. And so that's the kind of interface you do have, because that flexibility of working with Derek and his team to be able to put something instantaneously right after a traumatic event. Even post-election, there were some real struggles. And so we were guiding people to resources on Credible Mind that could help them navigate that.
Yeah, thanks. I know we just have a couple of minutes left. So Derek, I want to turn back to you with a short answer question, I think, and a little bit longer answer question. One is from the chat. There's a question about have the health systems designed the Credible Mind implementation to be a multi-year solution? And if so, like, what's the period of time? Is it 1 year, 3 years, 5 years? So I ask you kind of in general what you're seeing across the United States. And then the second question that's a little bit longer is you've told us a little bit about some of your interactive chat functionality that you've built but not released. What's on the horizon, as in addition to that, for the work that you're doing based on what you're hearing from hospitals and their communities?
Thank you. I assume you hear me now.
Yes.
Yeah, regarding contracts, very quickly, there's a full range. Everything from a 1-year contract to a 5-year contract, that is the range. We want to be responsive to what our partners want to do. But if there's an average, I would say it's around 2 years, 2 to 3 years would probably be an average contract duration. Things launch very quickly. Once people sign up, they typically launch within 60 days, sometimes less than 30 days. It's more about marketing. It's not about technology or that kind of work. The second thing, in terms of where I see things going, I'll make it brief, but 2 categories. They're sort of programmatically and technically. Programmatically, I think Julie and Debbie have given excellent examples of how a platform like this can be integrated into the workflow of partners in a community. Justice Department, schools, churches, United Way, on and on and on. So that is the real power. And I think we're going to see more and more examples of that. We're collecting those best practices and we're sharing them with people. So I think that's a direction we'll see a lot more of. Another is, I'd like to see a move more towards whole person care. We're talking about mental health and well-being, but we should be also talking about flourishing and physical health. And it's all one thing and it's integrated, and we're doing work in that area. And then the last part is what I'll just say, technically. Technically, we're going to see some interesting things. For sure, an AI conversational interface that's safe. But there's a fascinating work going on with things like passively collected biometrics, where your laptop, I've already used this, where your laptop camera can just look at your face. You don't have to answer any questions in an assessment. It just read and can reasonably diagnose a variety of different conditions and severity and start providing you assistance. Combine that with wearables that see how you're actually doing and think of real-time nudges. Hey, this would be a good time for you to do a breathing exercise or go outside for 5 minutes. So I think we're going to see wonderful things. Augmented reality, where someone with PTSD can just enjoy a 3D headset and calm themselves and work through prior issues. And I could just keep going. The technologies that are being tested today, they're not really out there in scale, but they work and they're coming, and it's going to be exciting.
Thanks so much. And that's got to be our last word. We are out of time for today's webinar. I want to thank Julie, Debbie, and Derek again for your insights and for the work that you're doing to support your communities in their needs. I want to let everyone know that this is the second of a three-part series. Our next webinar is coming up, if we can put our slide back up. And it's really going to focus on getting deeper into how do we understand and measure impact in terms of population behavioral health. That's set to be broadcast on Thursday, November 6th at 12 p.m. Central Time. So I hope that you'll register and join us. Again, thank you all in the audience for the work that you do every day. Look for this webinar and slide decks and other resources to come out shortly and be posted so that you can review them again. And we look forward to seeing you in a few weeks. Have a good day.